within just a 6-month audit, I found close to $500,000 left on the table for under billing and coding. And so it can be a major revenue loss for your group.
Yeah, I think that could be probably one of the most farthest from the truth statements, at least in my residency and training, and even what I see now among our residents here at IU Health. We have 6 residents a year, and I think we need to do a better job of teaching how to code and understanding some of the nuances of it.
Welcome everyone, and thank you for joining us today. I'm Zach Ruhl, the co-founder and CEO at Maia, where we have built an AI-powered medical coding and revenue cycle management software exclusively for orthopedic practices. Today, I'm joined by 2 exceptional orthopedic surgeons who bring deep clinical expertise as well as excellent administrative chops. First off, Dr. Szatkowski. He's a fellowship-trained, board-certified orthopedic surgeon specializing in trauma and post-traumatic reconstruction, practicing at IU Health in Indianapolis. And Dr. Hassan Mir, a fellowship-trained, board-certified director of orthopedic trauma research at the Florida Orthopedic Institute. Gentlemen, thank you for joining me today.
Thank you. Thanks for having us.
Between the 2 of them, Dr. Szatkowski and Dr. Mir operate on some of the most complex surgical cases within orthopedics. These are the exact cases where surgical coding is the hardest to get right and where the revenue impact of getting it wrong is the largest. So that's exactly what we're going to dig into today. Surgical coding, how it impacts an orthopedic surgeon's practice, the organization overall, and the day-to-day as they go about their practice. So to do that, we're going to play a little Medical Coding Mythbusters. Myth number 1, doctors are taught how to code and they come out of residency knowing exactly how to code. Dr. Szatkowski, we'll start with you. Let's bust that myth.
Yeah, I think that could be probably one of the most farthest from the truth statements, at least in my residency and training, and even what I see now among our residents here at IU Health. We have 6 residents a year, and I think we need to do a better job of teaching how to code and understanding some of the nuances of it. And I can tell you, even myself, I don't need to look beyond that. When I entered practice, when I started at Cook County in Illinois, and I was told, just dictate a note, we'll take care of everything else. And it was amazing looking back then. Like a year or 2 later, I took some coding courses and looked back at what was coded for some of my cases, and I was just like, whoa, things were missing, things were wrong, all the above. And so yeah, I kind of took the easy road, and one of the things that actually let me know about my coding better was when I was taking step 2 of the boards, and you have to submit your cases and the codes and everything. And I was just like, oh boy, I tried to correlate what my cases were on what I would code it and then what the hospital had coded it. And they were completely different, and almost, I would say, well over half the cases.
Interesting. And how did that impact you on a day-to-day basis? Did it impact you financially? I mean, what was the impact there?
Yeah. So I was very fortunate that it did not impact me financially, and I think that is rare. But it did impact the system. Even though we were a county system, we were trying to start now billing and collecting. And, it's hard to, I guess, really advocate for additional resources if it doesn't show that you're making money or bringing in revenue by what you're doing. So it did hurt me indirectly. It maybe didn't hurt my bottom line, but it hurt the bottom line of the hospital. And then, we wanted new C-arms, we wanted new, extra OR, extra resources. And that's where, you really feel the effect of, I would say, not coding appropriately as well in that type of system.
Absolutely. Dr. Mir, you used to lead the residency program at South Florida, so would love your expertise on this topic.
Yeah, so I think when it comes to our trainees now, our residents and fellows, you still see what I experienced when I was a resident, in that you maybe understand a little bit about CPT coding because you have to do your case logs that way. But really, that's about the depth that you understand, and that's it. I wasn't even aware, as most of my trainees early on aren't, that you have to have diagnostic codes that go with every procedural code that you do. And then the little nuances of how to enter those, how to order those in your billing versus in your documentation. And all these things kind of make a difference into your bottom line and how you get paid. So I think that there's a big knowledge gap. And, at the end of the day, during your training, the main focus is to learn how to be a good physician, right? You want to be a good doc in clinic, you want to be a good surgeon, but no margin, no mission, right? Even if you're working for a nonprofit, you have to bring in revenue appropriately and maximize that revenue appropriately to fund the mission of your work. And certainly, if you get into other private settings, then it's a much bigger issue with overhead costs rising and everything. So it's really critical to understand these topics as a trainee. And then if not, you're going to learn it on the job when you get out in practice, which was a big portion of my experience, even though I learned it quite a bit in fellowship because the fellowship here has a focus on that. But really out in practice is where the rubber meets the road.
Absolutely. I heard two things that I want to emphasize as well. That's number one, your diagnosis code has to match and map to the CPT codes that you're billing. You cannot be coding for a shoulder reconstruction and have the ICD-10 code still be shoulder pain. That will get denied, or you'll experience some other administrative disruption with the payers if you do that. And then the other thing is documentation. Your documentation is the foundation for everything that comes after it in the revenue cycle, not just the medical coding pieces, but should you have to appeal a denial or do a prior authorization or have any collections issues, the documentation that you put in is foundational to all those elements. So I appreciate you calling that out. Medical Coding Mythbuster number 2, the myth. If you are salaried or employed, you don't have to think about medical coding. Dr. Mir, let's start with you on this one.
Yeah, so that's a complete myth, and I'll give you a few examples, right? The first is my own experience at a prior institution, which was an academic institution, and we were all kind of salaried with a little bit of a RVU bonus structure. But, again, similar to Jan's experience where, hey, you could just do the notes and then we'll handle all the billing and coding on the back end. Well, I did an audit on our group, our division of trauma, and within just a 6-month audit, I found close to $500,000 left on the table for under billing and coding, and so it can be a major revenue loss for your group. And then I have a story of a former fellow who went to his job and was just really knocking it out of the park, clinically busy, doing the right thing. And when it came towards the end of his first year to calculate his RVU-based bonus, the hospital had one set of numbers, but he had kind of paid attention as a fellow and decided that he would track his own productivity and found out that he was shorted by at least a couple thousand RVUs, which in real dollar terms, if the average, orthopedic surgeon out there is making somewhere between 50 and 80 in RVU, depending on the contract you get, that can be a significant amount of money that you're leaving on the table. So I think it's important, no matter what practice setting you go into, to understand how these things are done and to track it on your own to make sure they're being done correctly.
Absolutely. Dr. Szatkowski?
Yeah, I think once again, that definitely that myth needs to be busted. I think people, even in an employed practice or salary practice, it's very important to show and demonstrate like what the value that you bring into that practice is. So if you're not able to show that with the CPT codes and everything, many times there's, discussion. They won't necessarily show you, I'm part of a big health system, and I've been part of a big health system always. And, they don't show you some of the downstream effects that your practice has. And but your surgical effects and your clinical in terms of E&M visits and so forth. And so that obviously leads to the further downstream effects for the system and for the group. And so I think you really need to understand that and, advocate for yourself and show the value that you and your group are doing for the system. And, a lot of, things right now, it's, hospitals get a, certain, whatever, it's like a DRG code. And so they get, a certain amount that they're reimbursed. But it's not necessarily always in the best interest of the hospital to show what you are bringing in necessarily, right? Those are competing interests. So I think it's very important to understand that. And when, to, be educated, like such as what you're doing, Zach, and what I know Hassan has done, for his fellows and everything. And we do that for our fellows now, that no matter what system you're in, whether it's private practice, salaried or RVU based, you need to understand those nuances that go into, your revenue generating capacity. And, it starts on day one, and it's important to realize what's going on and, and how you can affect it both positively and negatively.
Absolutely. I want to emphasize two things there, or maybe three things. Kind of education, and kind of the second thing building on that is the accountability piece. Understanding the process and kind of knowing what should be coded and billed based on that understanding really only helps you out as a surgeon, right? And as you have those competing priorities, having that base knowledge is only going to help.
I was going to add one more thing. Hassan mentioned, no margin, no mission, right? And I think a lot of times talking about coding, talking about billing can be very taboo subject, right? We're not supposed to talk about money, but I think when you say it like that, Hassan, I might steal that quote. I've heard it before, but I might steal it from you now and give you credit. Of course,
it's certainly not mine.
But I'll give you credit. Because I think that's key, right? And I think we're trying to also, that's like a myth buster, right? Like it's taboo to talk about coding, right? It's not. We should be educating each other, and a rising tide raises all ships. And
Yes.
And I think it starts with things like this and education of the residents, and even like during fellowship and beyond. It's something we should all be aware of because it surrounds us, whether we like it or not.
Right. And the last thing I wanted to add before we talk about future state is that accuracy is the most important thing. I think what we've seen in the market is that those competing priorities typically do lead to undercoding. Sometimes they lead to overcoding, but the emphasis has to be on accuracy so that you're accurately documenting and coding what you're doing in the OR or in the office and accurately getting reimbursed, which will lead to a margin that then supports and powers the mission of the organization. Let's move to the future state. So you are both at forward-leaning, influential organizations. Dr. Szatkowski at IU Health, Dr. Mir at Florida Orthopaedic Institute. Very different structures, right? Private versus a university, but still looking to understand how to improve medical coding for surgeries as well as office visits and the whole administrative process to ease that burden and improve the effectiveness. Wondering how you and your organizations are kind of thinking about how to lean into technology or where you see the market going as we go into the next year, 3 years, 5 years. Dr. Szatkowski, let's start with you.
Yeah, thanks. So I think, one, you already mentioned some things with like accuracy, education, and we want things that reduce friction. And, when we're doing these this coding, it should be, I heard this quote and I saw it online, that if it adds more clicks, people are not going to use it. And I think we're seeing that with a lot of AI programs, right? We have all this new AI for whatever it be, AI scribe, AI this, AI XYZ. And it hasn't been the improvement in efficiency as that we want. And I think coding really has that ability, right? It can cross-reference your dictations or your clinic notes, your operative notes, and really say, okay, like, was that information there? Is it already documented? And I think that's where it can make a big difference. And that's where I see it going, is that it becomes like one system. So it's not adding more work. It's almost like in real time. It's giving you that feedback of, an accurate code, because that's what's really going to help you, one, save admin time yourself, but then your own, pre-auth department and, appeals, denials, all that kind of stuff. If you can fix it on the front end and kind of hopefully reduce that and not create more work. So, I can maybe I see more patients, or maybe I just get home a little earlier, which would be great too. I think those things are going to be big wins if we can actually, translate that going forward.
Absolutely. Everyone would love to get home a little earlier.
Yes.
I agree with that. Dr. Mir, how about you?
Yes, I think there's a bunch of different ways to attack this problem, and it seems like most of the solutions out there are kind of attacking one part or another. And really, I think that it would be helpful to have somebody take a more holistic look at this approach. So there's the billing and coding side, right? And that's on the front end. And especially for trauma, it's really tricky, because for all of our elective colleagues who are pre-authing things and sending them in before the surgery is even officially scheduled and confirmed, you can kind of catch that process on the front end. But even they have trouble on the back end to ensure on the revenue cycle management side that you were paid what you were contractually supposed to be paid. And unfortunately, there's plenty of examples of payers not necessarily holding up to that end of the bargain. So that's a major piece of this that needs to be addressed as well. But then on the trauma side, I think there's the billing and coding. Obviously, we talked about the clinic aspect, but then in the OR aspect as well, because we don't always do cases that are straightforward, and we frequently have patients with multiple injuries and multiple things that may or may not be bundled together. And fully understanding that with software and AI-based solutions, I think will be really helpful, especially, for people coming right out of training, and even those who have been in practice for a long time, as Jan mentioned, and you mentioned, Zach, getting done earlier and freeing up more of that time is key. There's actually been a few recent publications on looking at small pieces of AI solutions in healthcare, and they aren't actually necessarily decreasing the total amount of time that physicians are spending on these processes. They're, making it somewhat more streamlined, but it's the total amount of time that docs are spending working on these things isn't necessarily seeing a major reduction yet.
Yeah, and one more thing with that, I think that's where you mentioned it earlier about accuracy. So it's not only the accuracy of our notes, it's the accuracy of the AI. And if we have to double check the AI, which I know some of those studies, Hassan, I know at least a couple that I've seen have, people have said like, oh, now they need to double check what was written. So even though, or what was done, so that even though it maybe does a note faster or something like that, well, then you're still looking at that note. So you're not necessarily saving that entire time. So, and I think the same goes for coding. We have to be able to trust it, right? We have to, trust and verify, but like if it's very accurate, I think that's where it can make even a bigger impact for us, because we're not second guessing it, going forward.
Absolutely.
And then on the back end, the ultimate goal is to provide good care, but then get compensated for that care, and managing it all the way through the revenue cycle, through the potential denials, appeals, and then ultimately reconciling things to make sure that you were accurately paid for what you really did, I think is critical.
That holistic approach you mentioned, Dr. Mir, I really agree with. And it's informing a lot of what we're doing at Maia. Gentlemen, I want to thank you very much for joining and sharing your expertise. We touched on a lot of things related to surgical coding, including medical Medical Coding Mythbusters. Appreciate you playing along on that. Dr. Szatkowski, Dr. Mir, thank you very much and enjoy the rest of your day.
Thank
Thanks
you.
a lot.
See you, Zach.